Okay, let's dive right into this explainer. Today, we're putting on our detective hats to uncover exactly how healthcare professionals systematically gather clues to solve the ultimate mystery, your health. It's actually a fascinating process that happens every single day, yet honestly, most of us barely notice the intricate framework behind it.
To guide our entire investigation, we're relying on a meticulously structured academic guide by Dr. Mohammed A. Mustafa. It's a fantastic, comprehensive look at the introduction and overview of health assessment. Basically, it gives us the perfect lens to see exactly what's happening on the other side of that stethoscope.
Seriously, have you ever wondered what really happens behind the scenes when a nurse or doctor walks into the exam room and starts firing off questions? It might just seem like polite conversation or maybe a routine checklist, but there's actually a highly specific scientific methodology at play here. Right off the bat, they are looking for clues.
To solve this mystery, we'll be following a clear roadmap. 1. The crucial first step. 2. Symptoms versus signs. 3. Methods of assessment. 4. The health history interview. And 5. Recording the chief complaint.
All right, starting with Section 1, the crucial first step, building the medical case. Every good detective needs a solid starting point, right? Well, in the medical field, and specifically the nursing process, that absolute most important starting point is what we call the assessment. Assessment is simply the collection of data about an individual's health state. The big takeaway here? This isn't just step 1, it's the foundational step. It involves gathering all the relevant information needed to solve a health problem. Without it, you are quite literally flying blind. All the remaining steps of the entire nursing process depend heavily on the accuracy of this initial info. If the assessment is off, everything that follows is going to be compromised.
Moving to Section 2, Symptoms versus Signs, Eyewitness versus Forensics.
So, when we start gathering this data during the assessment, what kind of clues are we actually hunting for? Well, we can brilliantly categorize our clues into 2 completely different buckets. We've got subjective data, which acts a lot like eyewitness testimony, and then we have objective data, which serves as our hard forensic evidence. Healthcare pros absolutely need both to crack the case, but they've got to treat them very differently.
The breakdown is actually incredibly simple. Subjective data, or the S, consists of exactly what the person says about themselves during the history taking. These are your symptoms. On the flip side, objective data, the O, is what the health professional physically observes. This is the hard data gathered by inspecting, palpating, percussing, and auscultating, which, by the way, is just a fancy medical term for listening to your internal organs. These are known as signs.
To really cement this, let's look at a real-world example. Let's say a patient comes in with an unverifiable complaint, like a sore arm. The pain they feel is entirely subjective, right? The nurse can't feel their pain or measure it with a device. That is a symptom. But the redness, the swelling, and the warmth on that arm that the nurse can actually feel and measure, those are verifiable, objective signs of the health problem.
Section 3. Methods of Assessment. How we gather the clues.
How exactly do we go about pulling these clues out of a real-world scenario? Well, we use 2 distinct tools to gather these 2 distinct types of data. We derive our subjective data from the health history. This is the conversation. Conversely, we pull our objective data from the physical assessment. That's the hands-on examination. 2 distinct tools, 2 distinct types of data. Makes sense, right?
On to Section 4, the health history interview, the systematic interrogation.
We're going to zero in on that first tool right now, the health history. Gathering this history isn't just some casual chat. It's formally broken down into 2 very distinct phases. First up is the interview phase, where the actual communication happens. And second, there's the recording phase, where that communication is officially documented into the medical record.
Let's look at the interview phase first. Honestly, this requires a lot of skill. Before even starting, the nurse needs to review the client's past health history. During the interview, you have to orient the client to the structure and expectations and carefully negotiate priorities. But here is where the real art comes in. The professional must find the perfect balance between letting the client talk freely in an unstructured way and jumping in to get the highly specific, structured information that's actually needed to solve the case.
As part of this process, we rapidly gather a massive amount of biographical data. We're talking about everything from their full name, birth date, and occupation to their religion, marital status, and social security number. But the absolute most critical part, the nurse must constantly evaluate the source and the actual reliability of the information being provided. Is this eyewitness testimony actually dependable? You have to figure that out.
And remember, the scope of this interview changes depending on the situation.
If a comprehensive initial database has already been collected, you wouldn't just start from scratch. You might conduct an interval health history for follow-up visits, just to see what's changed. Or if a patient comes in with a brand new isolated issue, you'd pivot to a problem-focused health history to collect data exclusively about that specific problem.
Which brings us to Section 5, recording the chief complaint. Filing the exact report.
Okay, so once we've gathered all this fascinating subjective info, how do we file our final investigative report without accidentally contaminating the evidence? It requires extreme precision during the recording phase. A healthcare professional must write adequate notes immediately, recording the history soon after the interview so details don't fade. Crucially, they must always clarify the exact definitions, terms, and descriptors the client used. You can't just assume what a patient means when they say, "I feel dizzy." You literally have to clarify their exact definition of that word. When it comes to the most important piece of the interview, the chief complaint, there's a golden rule. You ask the patient why they are seeking healthcare, and then you record their exact literal words in quotation marks. You do not paraphrase, you don't translate it into fancy medical jargon, you preserve their exact eyewitness account. A perfectly recorded chief complaint is beautifully simple. It reads exactly like this. I've had a headache for 3 days. It's direct, it's exactly what the patient said, and it tells the next medical professional in line exactly where to start their investigation.
To understand why this matters so much, just think about the difference here. You never want to write an improperly vague interpretation like, states that he has been sick. That tells the doctor absolutely nothing actionable. Instead, you want hard, exact, subjective evidence like swollen ankles for 2 weeks or fever and headache for 24 hours. That level of precision is exactly what cracks the case.
Which leaves us with something to really think about. We've seen how meticulously these professionals gather and categorize both what you say and what they observe. So the next time you step into a clinic and the nurse asks how they can help you today, pay close attention to your own words. Because whether you realize it or not, you are handing over the most vital, subjective clues to solve the amazing mystery of your own health.